Alright guys, in this video we're going to finish esophageal or some of the esophageal disorders that there are out there. We're going to talk about the hiatal hernias right now. We have a sliding hiatal hernia, and then we have a hiatal hernia where the actual fundus of the stomach actually slides up between this space between the connective tissue that actually creates a space. It's a connective tissue that binds here from the diaphragm to our actual spine, all right, in the thoracic region. And it binds on both sides, and in between that space is where the esophagus moves up and down. And a sliding hernia, sliding hiatal hernia, what happens is that it's just the esophagus that slides up and down as opposed to staying put where it is, and it changes the pressures, which, as we spoke about earlier, can actually cause GERD and reflux disease. Another thing that could happen is where the actual fundus of the stomach slides in this area, so the esophageal and the esophageal gastroesophageal sphincter actually stayed put, and they're attached because, remember, outside of all these connective tissues, the stomach is also somewhat connected, not very tightly. I mean, it's not a very tight connection, but it is connected to this connective tissue, so it shouldn't be sliding up and down, right? It should have just enough space for it to stay put, and enough tissue for it to not be sliding up and down. What happens with the stomach is that the fundus folds into the space and actually slides up into the actual thoracic cavity as well. Some signs and symptoms of this dysphagia can definitely be something. The feeling of being full without really necessarily eating too much, GERD, and reflux disease. And of course, you will also have the chronic dry cough. Okay, why the chronic dry cough? Well, number one, you're going to have irritation and stimulation of the vagus nerve around this area. Okay. The vagus nerve doesn't necessarily have to do anything with a cough, but remember that the phrenic nerve also runs right around this area of the diaphragm that the stomach, the fundus of the stomach will be herniating through, will be protruding through. Another thing that can happen is that the GERD can also irritate the lining of the esophagus so much, and that the GERD can actually increase to where it goes to the back of your throat and irritates the nerves on the back of your throat. I'm not too clear on how it happens, but irritation of the vagus nerve, aside from causing some chest pain, can also provoke a cough, especially if it rises up into your oral pharynx. So you have two mechanisms for this cough to happen: the direct pressure of the herniation pressing on the phrenic nerve and stimulating the diaphragm, and the irritation of the actual acids that wear down a little bit of the membranes, which is the same reason that causes Barrett's esophagus, but it also irritates the vagus nerve, the small branches of the vagus nerve, and acid actually reaching up into your oral pharynx, which also irritates your vagus nerve, which at that point it's not considered the vagus nerve, but it's considered the recurrent laryngeal nerve, or the terminal branches of the recurrent laryngeal nerve. And we'll go into more details on that when I do a cardiology video. And that's basically it for the esophageal diseases. One more, actually, that I take that back. One more that I want to bring up is esophageal varices and alcoholic complications like Mallory-Weiss tears and Boerhaave's. Esophageal varices are basically the veins that drain blood from your esophagus, and what happens is that in many diseases that could lead to hepatitis or cirrhosis, portal hypertension, the blood that drains from the esophagus is distributed. Some of it, the upper esophagus, goes into the azygos vein, which drains in with the superior vena cava into the right atrium, which has no effect on varicosities of the esophagus. The ones that do affect it are the lower esophageal veins that drain with the left and right gastric veins, and they do drain into the portal circulation. Okay, here's the splenic vein down here, and they do drain into the portal circulation. What happens is that in the portal circulation, these veins also become small again and microscopic, and the hepatocytes that are damaged and inflamed, whether it be in hepatitis, whether it be obviously not an acute hepatitis but a chronic hepatitis, where the hepatocytes are already dying and becoming fibrotic, which will lead to cirrhosis, okay, irreversible damage to the liver. These cells are no longer, number one, they're fibrotic, and they have swollen and they have constricted all the capillaries between them, okay? So this circulation around here is not working like it should. So what happens is that there's a backup in that circulation, okay? There's a backup in that circulation, and there's an increased amount of pressure. We have esophageal varices, but remember, at the same time, you could also have varices all around your gastrointestinal system, okay? The liver stops producing certain proteins, like albumin, for example, and you have loss in oncotic pressure. So what happens is that you also get dirt spacing into your abdomen, and you get ascites. But we'll go more into details when we talk about hepatitis and long-term complications of liver diseases, like liver cancer, malignancies, and cirrhosis. For now, let's stick to the esophageal varices. What happens is that the pressure builds up because these hepatocytes have become fibrotic and dead. So they have restricted the circulation around this area. So there's a backup, there's a buildup of pressure. And there is still circulation, because if not, you would die. But it's not that high, it's very low. So what happens is that it backs up, and you technically have an edema of these varicose veins, okay? Of these veins that are now become varicose. Varicose means that they have enlarged because of pressure, and they have become weaker than normal. These varicose veins will rupture, okay? In an individual who drinks a lot, you are constantly irritating, you may have a lot of reflux, and these varicose veins, these varicosities, are being exposed to that. So they become damaged, and you can have a bleed, okay? These bleeds will present with basically vomiting, and you will see mostly bright blood. However, you could have some coffee ground emesis if it's a minor varicose bleed that has been sitting around in the stomach acid, and the stomach acid breaks it apart and turns it black. Okay, the heme molecules get broken down, bind to the hydrochloric acid, and they no longer reflect that red color. It will be more of a darker brown, black color. And in a severe bleed, you will obviously see bright red blood. What happens is that with these patients, they come in and it's obvious they're bleeding through their mouth. What do you have to differentiate? You have to differentiate it from a Mallory-Weiss tear, a Boer-Haave, or you have to differentiate it from obviously an esophageal varices. Okay, the way that you treat this is you basically go in with an endoscopy. Okay, you always give a vasopressin, some type of vasopressor, whether it be epinephrine or actual vasopressin. And if you could possibly go via endoscopy and inject it into that area, it'll be great. But obviously you need a GI, a gastroenterologist, to do that. So you could give systemic drugs, vasopressor drugs, some that are made specifically for this, and you go via endoscopy, or a GI goes via endoscopy, and they will ligate or cauterize this. Okay, depending on the severity, it could be self-limiting. But if it's not self-limiting, that is a way to treat this. The next one that I want to get into is a Mallory-Weiss tear and Boer-Haave. They're basically very similar, basically the same. The difference is basically in the severity of it. Okay, in a Mallory-Weiss tear, it's usually caused from excessive vomiting or retching, violent vomiting. And you'll see bleeding. You'll see bleeding once again, just like you would before, with varicosities, right? Esophageal varicose bleed. Mallory-Weiss tear doesn't have that extensive bleeding, and it is self-limiting. However, sometimes it does require treatment with endoscopy, and the same thing, and vasopressors. Depending on how big the tear is, it may need some stapling or ligation. Boer-Haave, however, is a Mallory-Weiss tear. However, it's more severe, therefore it's no longer a Mallory-Weiss but a Boer-Haave. And a Boer-Haave is basically a tear due to retching, once again vomiting, but it's so big that actually a good percent of these individuals do die. Okay, the main cause for this is number one is iatrogenic, meaning that a doctor themselves during a surgical procedure or endoscopy may have caused it or provoked it. Okay, Usually it's an individual who has a worn down esophagus, or maybe a Barrett's esophagus, or already a diseased esophagus. And the bleeding is so extensive that I want to say that you could definitely go into hypovolemic shock, and you could definitely die from this if it's not taken care of within minutes after it happens. Okay, it's excessive bleeding, and once the blood irritates your GI, it'll stimulate even more vomiting and more hypovolemia. It's not a good thing. That does not reside on its own. It does need treatment right away. And I think that's it for esophageal. I think that's it for esophageal diseases. There's a lot of more esophageal diseases that I haven't gone into, but once again, right now I'm just trying to get a general understanding of medicine and the human body, and basic treatments. Like I said, if anyone wants more details on any of these diseases, I could make other videos on other diseases and topics that I didn't go into. On the next video, we're gonna start getting into gallbladder and biliary and pancreatic disorders, and how to go about them, how to manage them. Let's go.